Hello, What the HealthTech listeners. I'm your host, Rhian Bulmer. This is the podcast where we tackle some of the trending topics, ideas and best practice in health and social care. We're delighted to be joined this week by Director of Clinical Services from Exemplar, Helen Baxendale. Helen, hello and welcome.
Hi, Rhian.
You've got a really cool phrase on your LinkedIn that you use to describe what it is you do. Would you care to tell us and our listeners what that is?
Yeah, so within Exemplar Healthcare, so I always talk about making every day better, but that is our philosophy. And that is something that is really ingrained in everything we do at Exemplar Healthcare, that we're supporting our people to have the best days they can possibly have.
I think there's something really nice as well where you say it's for people to live, not be scared of a care home, but actually see it as something really positive.
Yeah, I've spent most of my career looking after people in care homes, whether it be elderly people or younger adults. And, you know, I've met many people with lots of different relatives, friends, healthcare professionals that have supported them. And I've always felt that some people fear coming into a care home. You know, you hear such bad stories on the media, in the newspapers around care homes and abuse that happens. But actually, there is so much great work that happens. And, you know, they're there for a purpose, and we look after people right up to the end of their lives. And I've always wanted to make sure that people don't fear that.
Yeah, I think that's massive because there is this fear of not just from service users, but from relatives, from family, of people kind of going into that environment. So have that debunked is something massive. So I think that's a really worthy tagline to have.
I always keep that right close to my heart. Yeah, I do.
So with that in mind, we were going to chat today just a bit about your background, what brought you to your role here at Exemplar, and what your kind of role encompasses, if that's okay, just as a kind of brief introduction.
Yeah, so I trained as a nurse in a nursing school, not at university, many years ago, and qualified in 1990. I worked at the local hospital I trained in for 6 years, and then I made a decision to actually go into the local care home as a nurse. Pretty much frowned on those days because you didn't come out of the NHS. People didn't want to go and work in care homes. But I loved looking after older people. So that's what I did. So I went into a local care home, and then throughout my career from 1996 up until probably 2016, I went through all of the roles that you could possibly do in an operational point of view. So I was a nurse, then a unit manager, deputy manager, home manager. I became a projects manager. Then I moved into regional management and finally up to operations director. And so I suppose I spent a lot of years, you know, right on the front line, supporting people, supporting care homes, regulation. And I got to a point in 2015 that I thought, you know what, perhaps I've had enough of actually being out there as the operator, but what could I do to make a difference to the people that live in the care homes, but also for the staff around how could I start to think about how we could improve what we do to meet the changing regulatory world with CQC, and actually back to the strapline of making every day better for people. So I predominantly worked in a couple of the larger organisations. I spent 10 years at Bupa, and then I moved out of Bupa and that's when I came to work for Exemplar Healthcare. So I predominantly looked after older people, dipped my toe every so often into some more complex care, but actually it was when I came to Exemplar, that was one of the things that attracted me, that it was really at my time in my career that actually I could learn something new. And I absolutely have had 5 years of learning something new every day about the people that we look after. And we look after the most complex people that you'd probably find in society that live outside of a hospital or secure setting. And many different people with many different complexities. So we look after people, just as an example, people with acquired brain injuries, and that could be through multiple things. It could be that someone's had an accident that's caused them to have an acquired brain injury, or it could be somebody that's had a stroke that's caused them to have an acquired brain injury. We look after a lot of people with Huntington's disease. We look after people that have complex dementia. We look after people with learning disabilities. We look after people with schizophrenia. So we look after a real range of complexities and a lot of comorbidities that come along with that. So just because someone's got a mental health problem, the majority of our people will have physical health issues as well. And it's very clear with an Exemplar. We've got 43 homes currently. We look after 953 service users. We've got over 5,000 staff. And, our values are very rich in the organisation. And the number one value is fun, which is fantastic. And believe me, every day there is so much fun that happens across our organisation. That is very, very clear.
I can attest to that working with you guys. You're a fun organisation to work with.
We're very proud of having that. And it's interesting when you look to recruit new people, and we always talk about the values, that actually everyone straight away just looks at the value of fun. Because to say as an organisation that is the main thing we want to do every day is amazing, really. And we support our people to have great days with lots of fun going on. Really good.
I think fun is a really worthy value and an important value, because actually most people want to have fun in life, in work, in how they live, and that's something really important. One of the things I'd be keen to talk about and explore is having such a complex suite of service users. How do you start to consider the quality and safety elements of that? Because that is quite a big feat to undertake, because there's so many different kind of complexities in the nature of what you do.
Yeah, well, we have to be very clear about everybody's individual primary diagnosis, and then their multiple other diagnoses that they have. And it's around understanding each individual person that we care for. And then it's around thinking about out of that, how we can support our staff to care for them.
Yeah.
So obviously there's an awful lot of training that goes on in the organisation. So understanding the service users and their complexities helps us as a team really drive the training agenda. So that's definitely one way. And I think you've got to have robust governance processes. And when I talk about governance, I'm talking about both clinical and I'm talking about operational governance. So an integrated governance programme. And very clearly, there has to be systems and processes that we introduce, follow, and actually all the time we're thinking about how we can reduce risk.
Yeah.
So we look after people that do have a lot of health risks, have a lot of behavioural risks, and obviously then that causes us across the organisation to have people that actually can injure themselves, can injure others. And so we've got to be very clear about the amount of support and training that we deliver to our staff for them to be able to actually deliver the care to the service users. So there's definitely got to be systems and processes. And in any sort of healthcare setting, you will have robust governance processes. So ours are not particularly any different to other organisations that you will find. However, we will then bespoke some of it depending on the type of service users. So we've got 43 different services and every one of them is different. And we have some specialist units. So we do have some units that may have 10 people with complex dementia, for example. But we also have units where we have a mixture of service users. So some people that will come in with a physical health need and people with mental health needs. And people have often asked me, how does that work? Well, it does, and it works beautifully because the staff know the service users really well, and we do a robust pre-admission assessment. And then the very key thing to all of that is the community fit. So we look at the people that we've got on a particular unit, and it's always in forefront of the minds of the home manager or the clinical nurse manager that go out and do the community fit, that will people fit in with other people. Interestingly, the other day I went to one of our services and we had an elderly gentleman who has got complex dementia who used to be a chef in his career. and currently is living in one of our 2-bedroom apartments with quite a young gentleman who actually we're looking to support to rehabilitate back into the community. And Ben is actually training Chris to actually cook.
Wow.
It was honestly, and they were both, I mean, Ben's got quite severe dementia, but Chris was so happy living with Ben because he was developing him some new skills so that actually he could be much more self-sufficient, and if he went out into the community then he would be able to cook for himself. And you would have never thought that the two people would get on and live together, but they do, and it's working beautifully.
I think that's really interesting as well, to look at the kind of formal side of having your risk and your governance frameworks in place, but actually what are the other metrics that mean a good quality of life, and putting those in place, and how you manage the two, I think is really elegant.
Yeah, and it is very, for me, we are, when we talk about individualised care, and you hear that across the whole industry, actually, given the type of people that we support, individualised care has to happen because every single one of our services is unique.
Yeah.
And no two one. You can have someone with an acquired brain injury that the level of care and support they require is completely different to the person that lives on the same unit in the next room who has also had an acquired brain injury. So we are very, very clear that individualised person-centred care is what we need and are required to deliver. And I think that's why it works really well, because we completely focus on that. How can we support this individual, and what are the outcomes they wish for? And that could just be, for one person, it could just be in a day that they've chose their own clothes or they've brushed their own hair. It's not always around clinical outcomes. It's around well-being and what makes people feel better.
Yeah, it's so important.
Yeah.
And so wonderful to see it articulated so openly as kind of all those small examples that make such a difference to someone. One of the things that you touch on, or you started to talk about, was that the staff training and that element of it being the underpinning piece that sits throughout. And how do you cope if you have changes in staff and fluctuations and
I mean, we are like any other company. We do have our recruitment challenges from time to time. We do have an awful lot of our longer term services that have very good core teams of staff that have worked in our homes for many years and have become their own community. But on the fringes of that, we have services that we do see staff turnover. It depends on the area. And again, it's around our recruitment process right at the very beginning, and looking for people that actually really do want to care for people with complex needs, because it is quite different than working in an elderly care home. And it's around understanding their needs and their developments individually again. So it's about, from a colleague perspective, a staff perspective, it's around understanding, what development they require and what trade, because we give every day we do mandatory training. We have our own positive behavioural support training. We have unlimited resources for training. We have a great platform that we can do digital training, but also we have face-to-face training. But actually, what we require to train one set of staff might be quite different to another, depending on the staff and their needs as well. So again, it's around investing in the people and understanding their requirements. And we have to continually do that. Staff will come and go, staff leave. And it's around our home managers and our clinical nurse managers and our nurses being able to support the staff to be able to care for the people. And so it is this constant circle, but it's something we have to do all the time.
I think that's interesting that you're cognizant of that you don't have a solution. It's a constant.
We run a really good buddy programme. So when a new member of staff joins us, everyone's allocated a buddy. And it's usually, obviously, we want buddies that have worked for us for a longer period of time, that understand the people that they're looking after, and that can support that new person in role. And that does work really well in most instances.
I can imagine. And I think as you're talking around that kind of complex environment that you operate in and having to constantly make sure that you're changing and adapting to fit the kind of variables within that. One of the things that we came to first start talking about was radar and the use of kind of tech and using systems within your processes to support that. What before you kind of had that tech that could change and amend? What did it used to be like? And I'm sorry, that sounds really cheeky, like how we used to live.
Not.
But...
So when I joined Exemplar, which is now it has just been 5 years ago, everything that we did was paper-based, which was quite interesting to me because I'd just come out of Bupa and we just implemented Datix. It had taken 2 years and I'd been sort of, for the care services group, been sort of leading that rollout and that training, etc., etc. And so I'd just left Bupa where I'd all of a sudden got this great system at my fingertips. And obviously, incident and complaint management is around reducing risk for any organisation. And so I left there having utopia, and then I came into Exemplar and we didn't have anything. Everything was completely paper-based. And there was governance processes, there was an incident framework, it was called adverse event reporting. So the processes were there, but everything was on a piece of paper. And then our sort of period reporting, because we work in 4 weeks periods rather than months, our period reporting, everything was on a spreadsheet, everything was manually inputted, everything was themed and trend. So you know, this big beast of paper and spreadsheets. And I was like, oh, wow. Okay.
Where do I start?
Where do I start? Well, obviously what I started with was looking at what the biggest risks were for the organisation. And for me, I obviously wanted a Datix or a radar. I just left that and that's what I wanted. However, I took the decision quite early on that actually one of our biggest risks was medication. So we implemented eMAR first. And so it was very much scoping out from a digital point of view what we wanted to do. And we're very lucky to have a great guy, James, who is our Chief Transformation Officer. And so our digital plan for the following 5 years, and we're just about there, so I can update on that. But the digital plan was then mapped out. And so we started with eMAR, and we've been on the journey for 5 years where we are now at the point, and obviously radar came in as part of that in the last 18 months, but we are now at a point where we're moving into looking at digital care records, and we will be using the Nourish system. We're just about to go into pilot in 3 services next week, actually, and we will have everything on a digital platform. So the journey has been massive, and in the middle of it was a pandemic, and that did stall us a little bit because we would have liked to have been further down the road with electronic care records at this point.
It's interesting that you say, you know, you sat down and you mapped out this 5-year plan, and I've spoken to quite a few colleagues across health and social care who are all saying similarly, you know, it isn't when you're committing to tech projects, you have to commit to a programme of work and a programme of activity. Because just one project on its own, it doesn't interact, it doesn't integrate.
And it's also, you know, mapping it out for 5 years change is really difficult sometimes for people. We want to change. We all want to change, and we know why we want to change, because we want better outcomes for the people we look after. But actually, when you're working in a care home every day, all day, with the challenges that brings, to then introduce change in so many ways all at once wouldn't work. And, you know, I was chomping at the bit to get incidents and complaints, and it took me 4 years to get there, which is fabulous because I've now got some great information at my fingertips, and so has the whole organisation. But actually, we had to take this on a steady programme. And our introducing of Nourish, we have an 18 months plan in mind, but if it takes longer, it will take longer. We will do this correctly and support our people. We've learnt loads, and we've certainly learnt around each individual care home. And some of our homes just take to change. And that's because of stability. There's a lot of stability in those services. So actually change comes easier to those people. Whereas we've got 1 or 2 services that we know we have to support more. Yeah. Because they do and are in areas where we do see some staff attrition, which then makes change harder, doesn't it, when you're trying to introduce something new.
Yeah, I think that, and I think it's an interesting topic around that whole, what are those, we call it resistance to change, but what are the barriers to change? And what, in terms of the rollout of programmes you've done so far, what have you seen those being, aside from attrition?
Yeah, attrition, I think sometimes it is around culture. It's around the culture of the people that are in the home and around their understanding. And sometimes we have to work harder with some homes than others. And that can be the dynamics of the staff team. Also, we have some homes where you can understand that that's difficult because the type of people that we look after, so the challenges in those particular services, they've got to find the time. Then we've got to find time to train them, to introduce the system, etc., etc. When you work in a really particular service that's really difficult from a challenging behaviour point of view, that's not always easy to be able to backfill shifts so that people can come off of their shift to be able to do the training. So I would say we've learnt so much having implemented eMAR, then a digital auditing platform. We've got a health and safety platform. We've got an electronic rota system. We've moved forward. We now know the services that do this really well, and we actually know the homes that we have to support further. And to be fair, that landscape hasn't changed. So in 4 years of introducing systems, it's still the same homes that still, and that's not particularly about their leadership. It's just about some of the challenges in the service, really.
It's interesting because this theme is just coming out in everything you talk about, that it's not one size fits all, not for your service users, not for your staff, not for rollout. It's really understanding the differences and the nuances.
Yeah, what we've also found is with any new technology that we're inputting that, it's great that we have a digital platform for training, and we do have to use that for various different sets of training. But when we're introducing a new system, we have really found that actually going out face-to-face to the homes, we get much better buy-in, and you see it settle into the service so much better. People do want, and I think COVID brought an awful lot of us having to do a lot of things digitally, that actually now we're opened up and we can actually get to services and we can work with people to actually introduce the training and what the system's about and show them the system. It works far better than bringing them into a classroom or making them sit in front of a digital platform and having the training.
It's funny that, isn't it? Because kind of as a tech industry, everyone's really, my whole career's been wedded to this classroom type approach to training, whether that's virtual or face-to-face. But actually, it's much more the practical side of people working, using their own kind of content and doing things.
It's having someone coaching
go.
them, I think, sometimes. So it's that coaching element. And that's certainly what we've used quite a lot of my clinical team to do, where we've got a home that's particularly struggling with the implementation of a new system, that actually some of my team will go out and actually coach them on an individual basis, coach the clinical nurse managers, coach the nurses, so that then we can do that cascade training. It is not as effective and accepted if we just sit people in front of the screen.
Yeah. But I think any kind of, I'm pretty au fait with tech, but anything new someone gives me, I don't learn it by watching a video, and then I learn it as I go, and need someone I can ring up and say, what is my password again, or what is the link to that? Or
So we've definitely found that working with people, being there on the ground, supporting and coaching where we have struggles is a much better method of getting people to accept the change and drive it forward.
Yeah. And I suppose it's having that foresight to know that actually up front that resource is required, but it saves you so much time further.
Well, there's more investment, but actually the output, both from understanding the system and the benefits that can bring, but the outcomes for the people is so much more positive.
Yeah, and I think that's probably one of the keys, being able to demonstrate the outcomes back to people.
Yeah, it is.
And on that, what kind of outcomes have you seen through your kind of digital journey so far that you're able to translate and show back to the homes, to the service users even?
Well, we have far more data available to us, and it's data that we've chosen to trend and theme every 4 weeks, and that helps us. improve the outcomes for people. So, for example, if I give you an example of one of them, so we now really capture unplanned hospital admissions, okay, which we used to capture them on a spreadsheet, but actually the level of detail, it was not as rich as what you get within a system. And actually, it's around looking at those unplanned hospital admissions. It's really important to our service users, as it is to any really, but actually having to go to hospital, the impact that can have on a particular person can be quite catastrophic with some of the types of people that we support. So we particularly fixed on this particular outcome so that we can try and avoid hospital admissions, which again takes pressure off the system as well.
Yeah.
It takes pressure off the NHS, and trying to work much more proactively with the GP practices to actually avoid unplanned hospital admissions, because the impact and the outcomes for people can be really poor when people have to go to hospital. And that's not, I'm saying that they don't get great care in the NHS, but actually it's not good for their mental health. Sometimes it's not good for their physical health. They're not supported as they would be within the care home because of the staffing levels within the NHS. So that's just one area. So having all of this digital information has allowed us to really trend and theme lots of things that actually we can reduce and see better outcomes for people.
I think that's really interesting as well. You talk about reducing and doing something with that data, because the fear a lot of colleagues have is, collecting data. We can collect really good data and we can have loads of dashboards, but it's actually bringing it to life and doing something with it.
It's also, we've got it, so from a central perspective, it's all there, we understand it, etc., etc. But one of the key things for me, and something that we're really on a journey within Exemplar, is helping our colleagues in the care homes to understand what it actually tells them.
Yeah.
And to become quite self-sufficient in using the systems to actually understand where their issues are, where the risks are, and then how they can respond and react to that really quickly. So currently we support centrally, but we are, as a system becomes embedded, and we've really seen this with eMAR and we're now driving this with Radar, is, in the initial stages, we're really supporting the individual services to understand what it's telling them. But as we go a year into post-projects, we're backing away and trying to get people to understand. So it's back to training.
Yeah.
It's going back out to services to support and coach them to understand what this information is telling them and what it means for them.
And have you got any examples of where that's really come to life? Because something comes to mind. A GP colleague once said years ago to me a phrase that stuck with me ever since, that actually the power of data is you don't have to let other people measure you. You can measure yourself and you can track yourself and see that. So have you got any examples of where the home managers have had some really brilliant changes they've been able to make as a result of seeing that data? Yeah,
I think we've got a particular service where we've had quite a lot of service users that have fallen. So I think about the particular unit, I'm thinking about a lot of people with complex dementia and a lot of falls. And really, now that we also track falls and the trends and the themes, actually that home has dramatically reduced the falls within their service. And obviously, from an outcome-based point of view, that's fantastic for service user care. And we've got a lot of examples of that, certainly from a falls perspective, a choke perspective. Also, when we look at injuries caused through physical altercations, because obviously we have a lot of people that have behaviours that challenge. And actually, we've seen quite a vast reduction over this year in something that's resulted in an injury by trending the data, knowing which homes have got particular pockets of it, and then actually our behavioural support team going out and supporting the services to understand what measures they can take to reduce the risk.
So, not wanting to put words in your mouth, but would you say that it's actually through analysing your data that you're able to run these bespoke programmes and bespoke training programmes, because you get to exactly know where your hotspots are?
Because we don't need the same thing for everywhere. So back to the whole discussion we've been having, all of our services are very different. So I don't need to run a falls programme. I mean, we often have themes of the period. So we'll have we had a smoking cessation theme because we have a lot of people that smoke in our services. We do have a falls theme. We're just about to do a meds theme, but actually we can help the homes understand the data, and then we can per home bespoke what extra training they may require, because what one home will need is not the same as what another home will need.
And then that allows you to have that flexible approach you've talked about.
And use our resources much more impactfully across the organisation.
Yeah, that's brilliant. And it's exciting to see, from our point of view at Radar, to be able to see the real examples of the system brought to life and affecting change, because that's why we're all here and why we all want to do it. But being able to see that and see those stories is massive.
Yeah, no, it's fantastic. We've just been building a choke risk register within Radar, because we had a significant incident in a service around choking. And actually, that has really highlighted to us where our risk is. And we've now just commissioned the services of a speech and language therapist who's going to work with the organisation. And actually, we are just developing a bespoke training programme for everybody, for every service that requires it, because not all services do.
Yeah. That's one of the most exciting things to say. I'm trying to think of a kind of tagline for it, but it's not come to mind. I'm sure you'll think of one. I have one.
Yeah. It's the power of it, isn't it?
Yeah.
It's just knowing that you can look at each home individually and then support them individually, instead of just running, training sessions that you want everybody to come to.
Yeah, and I think it's something about that adoption and use of tech, because certainly through COVID, and you saw kind of every investor investing in health tech, it was the thing. Everybody's got lots of good ideas of how tech can help, but actually it isn't this kind of blunt instrument where you put in a system and it fixes loads of problems. It requires
the system's as good as what you put in it.
Yeah.
It's as good, and it's also as good as the people that use it and their knowledge of what it means.
Yeah, and then what you do with the outputs of it.
Yeah, absolutely.
And then that kind of evolution you talk about, of that constantly changing circle, the tech's got to be able to fit and be spoke to that too. It can't just be this kind of raw instrument that's just always there as a static.
Yeah, absolutely.
I think that's to hear those stories is really heartwarming for us, because we get to hear the real examples of it being used, and ultimately, making sure that everyone is having fun.
And we're at the stage, so we're now live in all services, but we're now in the embedding stage, which I find really exciting. So we've got so many more incidents reported than we've ever had before, and it's great to see our carers and our senior carers and everybody now inputting into an electronic system. But it will take us a good year, and my experience of running this type of system elsewhere is that you've got a year of learning and embedding until it becomes that much more, it becomes part of what we do. We're not quite there yet, but we are seeing more and more incidents reported. I get so excited. So Dan, who runs the project for us, will say, we've had 7,258 incidents reported now, Helen. I'm like, yes. This is what I want to see. Obviously that also includes near misses, etc. But we can learn so much from that, and I get really excited by this.
And how do you foster that positive culture that people feel that it's safe, it's psychologically safe, it's right to report? Yeah,
well, it's around how we communicate, isn't it? About what the system's telling us, how many incidents we've had, and actually it's that positive reinforcement that keep reporting, report, because at the end of the day, that's the only way we can learn. And we have a steady sort of communication program with an Exemplar, so we have our weekly communications, etc., and we talk about this all the time, so it's constantly positively reinforcing to people that this is really good. Don't feel afraid that you've reported this amount of incidents, and obviously every 4 weeks we report on all the incidents, but actually you're doing a great job, and this is what you can learn from. So you've got to constantly praise people for the fact that they are reporting.
Yeah, which is culturally in a lot of health and social care organisations a sea change to, actually pulling it all out there and everyone being really transparent. Not suggesting people are not transparent, sorry, let me rephrase that, but actually filling it into a system to know that actually as a whole you start to be able to spot trends.
And it's why we do it.
Yeah.
So you've reported this incident, and, we do an awful lot about lessons learned, and, I personally send out any significant lessons learned from an organisational point of view, and I love to send those out. And that's a double-edged sword, really. We don't want a significant incident. However, the lessons that we learn, I really smile because I send it out and I get so many responses back to me about what people are doing about it.
Yeah.
And thanking me for sharing the lessons learned, that I actually feel that we are really driving forward with this learning culture about what we do. And we need a system like Radar, like eMAR, all of those systems to be able to learn lessons much more quickly.
Yeah.
Because again, it's back to support staff to be able to deliver the care and actually support service users to get better outcomes.
Yeah, and I think that going right back to that point about supporting staff, nobody comes to work to do harm or want to do harm. They want support and help in how to mitigate these risks and prevent them.
Yeah. So we just communicate about it all the time.
Yeah.
We have business update calls and I talk about how many incidents we've had and, the positive reinforcement of you doing a really good job.
Yeah. And so how does that fit into, from those incidents that you see, how many of those fit into that wider system? So I've got questions on here about the wider system, so I'm trying to steer us into that kind of direction. But how do you start to look at those incidents and go, okay, they sit within this organisation, or actually these incidents have sat within the system as a whole?
Yeah, I think when you look at a system, for me, obviously, the more you capture, the more you can actually develop and learn. So I think working in partnership with people like Radar, but working in partnership also with the NHS, the ICS, the CQC, working in partnership, where we've got these systems and we capture all this data, we should share more so that we can all learn from it more.
Yeah.
And I think where we're developing systems, and for the people out there like yourselves that go out and develop a system, you've got to know who your stakeholders are that are actually going to use the system and what they're wanting to get out of it. And I think then for me, it's really key that you then use the people, you involve the people that are going to use the system to then develop it. Does that make sense?
Yeah, absolutely. And I think there's something, certainly some of the work we're starting to look at is we have experience in social care, in healthcare, hospitals, primary care, all these different elements of what makes up a healthcare system. But how do we work with our colleagues to join those dots?
Absolutely.
Because the data's there. It's about joining the dots to give insights across that whole view rather than everything sitting in silos. And someone from NHS Digital once said, quality and safety is the falls between the cracks of the organisations.
Yeah, I think, as you look at the industry as a whole, and I've been on a 5-year journey with Exemplar of we are transforming into this total digital platform, but we're not the only ones.
Yeah.
So, you talk to people that in the industry, and everyone is on this drive now to be on this digital platform. So we'll all be using something similar.
Yeah.
It's how we then all join up and decide that we can work together and share, which we don't do well, do we?
Yeah.
To be fair, when you look at organisations, our organisation versus some of the other organisations, we're not good at doing that. So as we're all moving to a digital platform, then I think there should be so much more scope for forums and discussions around what we are highlighting and what we are actually doing to reduce risk for people. Because actually, if we did a lot more sharing, then the outcomes could be much improved all over.
I think there's probably a few different themes to pick out from there. One is the sharing against similar organisations to look at actually this is what happened and these are the mitigating actions we put in place. And I think that's really powerful. I think there's something then, we've been asked by a number of our colleagues to actually start to look at data at that level.
Yes.
And start to say, well, actually, we're seeing this trend of falls and actually how does that link with training or this trend of med errors, how does that link back to primary care and med reviews or and starting to tackle things problem by problem, but at a system level.
Totally agree.
Because I think sometimes what we see is, or what I observe of the systems is, everybody's coming at them, fix these problems. Everyone knows what the problems are, but it's actually taking them piecemeal and tackling them.
And we've all got similar problems.
Yeah. What would you say your top 3 problems that are system-wide, kind of endemic of the system?
I mean, there's definitely, when I look at our data and the things that cause us the biggest risks, and I'm obviously have a lens on them all the time, there is definitely something about medication. I think across the industry, there's millions of errors per day. Now, they're not errors as in somebody's being given the wrong tablet. We're talking about stock counts, etc. So there's definitely something around medication that I think as an industry and joining up with our partners, allied healthcare partners like the NHS, that we could potentially make steps forward in that area. We obviously look at falls. Falls can be prevented, whether it be down to people's medication being changed, whether it's down to footwear, whether it's down to observations. So for me, I've always got a real close lens on falls. And then clearly in our industry, because we look after, in our particular organisation, we look after people with challenging behaviours, we have to look at trying to reduce injury to people. Yeah. So from a system perspective, the systems we've now got tell me all of this.
Yeah.
And it's then what we do about it, what we do with that information, and then what we do to support the people, our colleagues that deliver care, and then the service users.
Yeah. And that line of communication between all the different organisations.
Yeah, because other organisations will be having exactly the same issues.
Yeah. Yeah, and I think that's something that certainly we want to work to at least foster the environments where organisations can speak to each other, because there's definite appetite there. Everyone's asking for relationships to be facilitated.
And for me, when you look at the systems and the workflow, the lessons learned bit is probably one of the most important parts.
Yeah.
So within the system, within your system, my challenge would be, could we have a lessons learned platform where we share across the industry lessons that we've learned?
I'm going to say yes, but anyone listening in product that I'm going to get in trouble from. But there's nothing to stop us exploring that.
When you think about it, that's one of the main things that we want. We want everybody to be safe.
Yeah.
So if we've got lessons that we learn across industry, actually, you pick some of the lessons learned up through the media. So you do, when you see things that are in the media about something that's gone wrong somewhere. But actually, if we're all using a similar system and information's kept there, if we all agreed that we were happy to share our lessons learned, then why wouldn't we?
Yeah. Yeah, and maybe there's something that we can do that in a much softer way to start with by just having those meetings with one another. Yeah. I've got a cliche, acorns, small acorns,
absolutely,
mighty oaks. But no, I think that's certainly something that we're hearing from across the estate. Like, actually, let's start sharing what we can do with this data and coming up with examples, and then going outwards to within ICBs or whatever that might be to say, look, actually, we think this is a solution that could help. And I think certainly as tech providers, we have something where we're culpable for helping join up those dots and not just sitting within our own system. So, for example, we're working on integrations with Nourish, we work with IoT devices, all these different things. And we can go off and dream up all the wonderful examples that we want to, but actually to have real tangible examples of problems we can fix, we can go and find the right partners and build those scenarios. So I think there's definitely a challenge back to us as tech providers around that, around bringing the kind of information you're putting into life.
Yeah.
I'm looking at the questions here, and I think I've asked you them all. Now, I've got some kind of really quick fire questions, as in, what do you think the key principles of effective working across the system? And by that, I mean across an ICB, for example, with you mentioned your GP partners, or hospitals. What are the kind of key principles for that we could learn from?
Well, there's definitely something around communication, isn't there? And I think I talk to my care home managers, I talk to everybody within our organisation, and everybody still seems to do things quite differently, don't they? So you go from one area, one ICB to another, and never the twain shall meet, and they do things differently. So it's not easy, is what I'm saying. But actually, if we know who our key stakeholders are within each ICB that actually can drive this agenda, then I think that would be really rich. Now, in my own organisation, I know some of them, but not all of them, and it's not always that easy to find out. So we can have as many systems across the adult social care sector and want to link in with ICB and et cetera, but actually if we don't know who the key players are and the stakeholders are out there, then that's really difficult, and I find it difficult sometimes to find that out.
Yeah.
So I would say from a systems perspective, I think we've now got a digital world and a platform where we could really link in to our partners from an ICB perspective, and actually into some of our NHS partners and GP practices, but actually it's too disjointed.
Yeah.
So we're not there yet, and I haven't got any answers, but we do need to, I think, work much more coherently together. Because the ICBs come in and quality monitor us. They know what systems we've got. They know what data is available to them. And everyone's getting much more au fait with all of the systems because Radar, Nourish, eMAR, they're all out there in the industry, so people are getting used to using them. But I'm not so sure we fully understand what they want from us.
I think there's something around that discussion, from that quality metrics point of view within systems, because if we know what you're being asked, we can help build our standard dashboards, we can all work together on it, and there's maybe something to be learned from the kind of micro example, and by micro I don't mean small, but the example you've given of having to work on that bespoke evolving programme internally, and I think that maybe that's something that has to happen when we look to the external market, to the ICBs, to start to go, well actually, piece by piece, how do we fix things and how do we help?
Because they all ask us for different things as well, which is not helpful sometimes. Right. So depending on which area we're in, occasionally we get asked for different metrics to another area.
Right.
I mean, we generally have the information. It's not a problem to find the information, but it's not consistent.
Yeah. And then so everyone measuring the same way.
Yeah.
Okay, there's something definite in that and how we support that and how we support
standard set metrics that people want us to report on. And then there will be bespoke metrics because we look after people that are more complex.
Yeah.
So we will then have to measure other things. But currently, we don't. It's not standard. Similar, but not standard.
And if we could get the standards right, and then it makes the bespoke stuff just easier.
Yeah, it does.
Yeah, add on. It's been really interesting chatting this morning because I think there's probably the main theme through everything is the ability to have standard systems and processes that flex consistently and constantly changing and evolving, right from your staff and your staff training to how they're implemented across your homes as to what support different homes need across what we might have to do in the system around that, and always having that flexible approach throughout, which isn't easy and doesn't give a blueprint, but at least if we could start to have a blueprint to work from and adapt makes it easier.
Yes.
So I think that's been really interesting to hear that. Do you think that's a fair enough summary?
Yeah, I do. And when you look at all across adult social care, governance processes are similar everywhere.
Yeah.
Just, we are an organisation that look after complex people, but our governance processes in our services will not be any different, might be slightly tweaked, but not any different to what you'd find in an elderly care group. And we all work to the same CQC regulatory standards.
Yeah.
So there has to be a level of standardisation, which we all have, which we then build on. So we are all looking at the same things and gathering the same data and wanting the same outcomes.
Yeah.
Yeah.
So there's two takeaways, certainly from our point of view, that we'll take back. One is how we link up for you guys to share the outcomes of what you've achieved between one another as colleagues, but then how we can start to work with you on that standardised blueprint approach within the system.
Sounds great.
Yeah, right, well, you can hold me to it.
I will.
Now, before you go, we have to ask you, now I'm checking here, we have to ask you, what is your health tech moment? So the guys who normally run the podcast say they normally ask a question about what's your health tech moment, what's your weird, your wacky story. Have you got one, Helen?
I have. Okay, so I thought about this long and hard as I was driving here today, and I am going to share this. It's quite funny. But actually really poignant. Okay, so I joined, as I said, Exemplar 5 years ago, and at the time I had a great CEO called John, quite a wacky guy, really, quite entrepreneurial, full of life, etc., etc. And we have and we still have exactly the same council. We have a service user council. And the council meetings are amazing. And this was pre-COVID. So every one of our council meetings have always been pre-COVID, face-to-face. So we would have a group of 25 service users that have been nominated as the service user ambassador for their service, and we would have a venue and they'd come to the venue and we'd listen to them. So it's around the executive team listening to the service users and then trying to make changes or adapt something at their request and what they wanted. So, and they are so lovely, and we have a very different bunch of service user ambassadors. But one particular guy called Chris, quite a vocal man, who is always championing our staff, wanting. So every time you go to a council meeting, he'd talk about staff pay, for example. Really a champion for the staff. You don't pay them enough. So, but Chris would always have a slot because Chris had and still has a lot to say. So this particular month, it wasn't my turn to go, so we take it in turns. And also, depending on the themes and topics that go onto the agenda, one of us would be allocated or two of us to go. But this particular time, it was John. So off John goes to the Service User Council meeting, and as always, Chris has his slot. And the first, and it is normally the same. He asks and talks about the same things, which is usually about the staff. So John had obviously gone prepared to talk about the fact that salaries were going up, minimum wage was going up, blah, blah, blah. And so it got to Chris, and Chris said, "John, I need you to help me have sex." Which completely and utterly floored John, who was never speechless about anything. But he actually stood there, I'm told, and said, "Chris, I'll send Helen Baxendale next time and she'll sort this out." So, and this story has been told many times that he just didn't know what to say and said he was going to send me to sort it out. So he came back and said, "He said this." And I said, "Okay, what did you say?" And he said, "I told him you'd sort it out." And I was like, "John, that wasn't the right answer." He said, "I know, but I didn't know what to say." So it's a funny story, but actually it made me sit and really think about things. So it wasn't long into my exemplar journey. And obviously we predominantly look after people of a younger age group. However, Chris is not, you wouldn't class Chris as the younger age group, okay, because we do look after older people as well. But actually, this was something that I thought it was a topic that we potentially would be able to talk to service users about, would be able to support service users, okay? But actually what I quickly learned, and it was that moment, that actually I'm not sure we are very good at supporting people in this particular way. So it really set us off on this project. And so I knew some people at Leeds University, so made contact and partnered with a lovely lady called Jane to undertake a research project for us on sexuality and intimacy in care homes, because it was something that I thought, well, I'm not an expert in this area. John seems to think I'm an expert on everything. But I thought, well, if I'm struggling with this, how do our staff support our service users? And clearly people could struggle to have these types of conversations. So we undertook some research, and Leeds did it for us, and the project was around sexuality and intimacy. And Chris was one of the participants of the study, so Jane went off to meet him, along with a number of other service users, and after about 3 or 4 months, produced us a great research report that actually, and this was one of those moments where, you're just like, it was one of those moments. The majority of people that live in our homes through the research actually said their lives, it wasn't about having a sexual relationship, but they just wanted to have friends.
Oh.
And honestly, it still gets me now when I talk about that. So again, that's a moment of what are we going to do? Okay. So Jane introduced us to a great organisation called Enhance the UK, and they are disabled. It's a disabled organisation, so it's disabled people helping disabled people. So we joined up with those guys, amazing group of ladies, who helped us develop some processes and policies around the topic, also enhancing our care documentation, but also developed us a fabulous interactive training programme to deliver to our staff teams so that we could actually support them to have this type of conversation that Chris had raised at the Service User Council meeting. And interestingly, usually they would go out themselves and deliver the training, but the pandemic hit, so we agreed to do Train the Trainer, and that programme and is still really widely known, and we use all of that work that came from that one conversation in the Service User Council, and I have no doubt that we have absolutely supported people. Not just our service users, but our staff to be able to have those conversations and actually support people.
I've well to put that. That's the most beautiful story because, well, one, good on Chris for standing up and saying
Absolutely.
what he thinks. Two, good on John for listening and bringing it back, albeit to you, and actually fix
okay.
it. Yeah. But also for you as an organisation to really stop and listen to actually what impacts someone's quality of life and what's important to service users, not just what we think's important, and that real true quality.
But again, it's back to that point about fear of coming into a care home.
Yeah.
Because I think people come into a care home and they think that part of their life could be over.
Yeah.
Actually, that's not true at all.
Yeah.
And it was very clear to me that we needed to do something different, and we absolutely have done something different. And I know that that's helped staff support the people that we care for.
Yeah. Well, I wouldn't be surprised if our colleagues write in after this asking to talk more, because certainly
Absolutely.
Speaking to other radar users, there's something around that quality of life metric and how do you start to improve that?
Yes.
'Cause that's so important.
Yeah.
So I won't be surprised if you get questions, but it's not. Maybe we have a column, Ask Helen.
Ask Helen.
A new podcast, yeah. John can set up, Ask Helen to fix it.
Oh, no.
But that's such a beautiful note to end our discussion on, Helen, in terms of your passion for your role, Exemplar's passion for service users, for staff, for making sure that everybody is having fun but having a quality of life, and a quality of life from an employee perspective as well.
Yeah.
So thank you so much. Thank you for your time.
No problem.
Thank you for joining. Don't forget to subscribe if you've got questions you want to hear in the future, if there's things you'd like to see in this podcast. I've got the address here, whatthehealthtech@radar.com, so send any feedback, any thoughts to us. And thank you very much, Helen.